Good afternoon, my name's Anne Gold. I'm a consultant adult diabetologist working in Aberdeen, and I'm going to present the data from the subgroup looking at the management of people with type 1 diabetes and an eating disorder. Just to give a bit of background, type 1 diabetes is a disease characterized by elevated blood glucose levels, which are due to a lack of insulin production and require the patient to monitor glucose regularly and inject insulin several times a day. They also need to calculate insulin doses depending on their carbohydrate intake. It tends to affect younger people, although not exclusively, and it's not lifestyle related. There is a measure called the HbA1c, or glycated hemoglobin, which gives us a rough indication of glucose control over the previous 2 to 3 months. In type 1 diabetes, it's been estimated that eating problems are probably twice as common as in those people without diabetes. Diabulimia is a term you'll often hear used when it refers to an eating disorder in the presence of type 1 diabetes. The mortality rates for people with eating disorders and diabetes are significant. They're about 4 to 5 times higher than those with anorexia alone, and 15 times higher than those with type 1 diabetes alone. It has been estimated that about 40% of women with type 1 diabetes will omit or reduce insulin doses in order to lose weight. And there are a number of common features which would alert us to the fact that somebody might have an underlying eating disorder in the presence of type 1 diabetes, which would include insulin omission, poor glucose control, recurrent admissions with hyperglycemia and ketoacidosis, which is a life-threatening condition, disengagement from diabetes care, concerns about being weighed, not willing to share glucose results or even to test at all, and concerns about weight gain caused by insulin. There were 4 questions that the subgroup looked at. Those were looking at psychological therapies in children and adults, and then the second set of questions was looking at the pharmacological therapies. However, it rapidly became apparent that we could not separate the studies into children and adults, often because either age wasn't specified in the studies or that the threshold crossed where we would normally distinguish between age and children, for example, studies age 12 to 19. And results were often not reported separately for the older and younger subjects. So we combined them in the 2 questions. The outcomes we used were similar for both of the questions and similar to those we previously used, but we added some diabetes-specific ones, which I've shown in red. So I'm going to start with the pharmacological therapies first, that essentially there were no studies that provided any data on the use of pharmacological therapies in improving outcomes in type 1 diabetes, so we were unable to make any recommendations in this area. In terms of the psychological therapies used in the treatment of eating disorders and type 1 diabetes, we found 1 systematic review and meta-analysis. And this comprised only 6 studies which were reported adequately for inclusion, and only 3 were included in the meta-analysis, and it's a total of 205 subjects altogether, so there's not a lot of data. Many of the interventions were not described in adequate detail for The interventions were divided into inpatient or outpatient interventions. The inpatient intervention was longer, had daily interventions using psychoeducation, CBT, family therapy, and in particular supervision of diabetes. And the approach was very much combined with input from the specialist diabetes team, and it was run in the specialist eating disorders unit. The outpatient interventions were shorter, tended to be weekly, and it was noted that there was poorer uptake. So the outcomes, so HbA1c is a measure of glucose control and indirectly insulin compliance. 3 studies only had adequate data for inclusion. The timescales were variable and possibly too short for some, but the inpatient data showed that a significant improvement in HbA1c, and for clinicians in diabetes will recognise that a drop in HbA1c of 29 millimoles per mole is highly significant. These patients started off with high HbA1c, which may indicate that they were people with more severe eating disorders. The outpatients had a fairly small probably clinically insignificant drop in HbA1c. But again, this may have been measured too early for it to be meaningful. And again, these patients had a lower starting HbA1cs. The other outcomes that were looked at included the eating disorder inventory, and 4 of the 6 studies that were looked at showed improvements in these scores. No other data or outcomes were available, such as DKA admissions. So there's limited data, but we did feel we could make the current recommendations that integrated intensive specialist care, which is a combined involvement of diabetes health professionals and mental health professionals, probably in an inpatient unit, may be considered where there's a patient who's particularly high risk of complications with type 1 diabetes and an eating disorder. And secondly, that healthcare professionals should consider managing control of insulin administration alongside the psychological interventions. We did include some best practice recommendations, and those were that patients with type 1 diabetes should be screened for eating disorders, as has already been suggested in Sign 116. And that healthcare professionals with diabetes, who are looking after people with diabetes or eating disorders, should be aware that the common practice of insulin reduction to avoid weight gain, and also the cluster of significant characteristics which may alert the health professional to the fact that this patient may have an eating disorder. And lastly, we recommended that the Mental Health Act should be invoked when necessary to oblige patients to accept insulin to save life or prevent irreversible damage. Thank you.